use those as resources. We're going to start things off with the respiratory disorders. So again, oh, yes, question. Abigail.
Sorry, I'm like going out of the library right now, but you said there was a 15 question thing. The only practice exam that we had for that doctors always told us about is like 50 practice questions, but he said that the questions that we had were the same every single time we took it.
So there's like one on Canvas, I think, that shows that it's due Tuesday night at like 11:59, like on Canvas. That one has a really, really big test bank. So I think there was one that was like in person, but if there's one, at least on my like instructor's end of Canvas, I'm seeing one that's due like Tuesday 11:59, where you can kind of use that for practice questions.
Okay, thank you.
Okay. And did someone else have their hand raised? Okay. Well, if you guys have any questions, pop it in the chat, interrupt me, whatever you need. Let's begin. So here's some things that we're going to focus on when we're talking about tuberculosis, specifically the differences between active and latent, how we test, etc., some medication considerations, and how as nurses we can keep safe. So when we're diagnosing tuberculosis, it can be split into two categories, your active TB and your latent TB. When someone has active tuberculosis, it means they are actively experiencing an active infection and they are capable of spreading the disease to others. They're going to be showing those signs and symptoms of the hemoptysis, which is like a bloody cough and sputum, low-grade fever and night sweats, as well as a persistent productive cough. Again, chest x-ray is going to be our gold standard for diagnosing active TB. Okay? Additionally, when we're talking about latent TB, these individuals are not capable of spreading the disease. However, the disease can go from dormant to active in the event that the host's immune system, for whatever reason, weakens. And on a chest x-ray, people with latent TB, you'll actually see like coin-like lesions on the chest x-ray. So you'll see the lungs and you might see a lesion that kind of looks like a quarter. That's going to show us our latent tuberculosis. It is an airborne disease, so therefore we need to implement airborne precautions, such as wearing an N95 respirator, our protective eyewear, our gown, our gloves, putting the patient in a room by themselves in a negative pressure room, and if we need to transport the patient, putting a mask on the patient. Okay, lots of different risk factors, specifically our ER nurses, those with a history of IV drug use, alcohol abuse, etc., are at increased risk for tuberculosis. A couple different things we can do to test. Our NAT test is really quick and it helps us confirm a diagnosis. Also, for patients who may have had tuberculosis in the past, that will show up on the tuberculosis PPD test. We all have to get that done for nursing school, where they do a subdermal injection and it bubbles up, and in a few days the bubble should go away. If it doesn't, that means that person probably has latent TB. So at one point in time they did have tuberculosis, but again, if they're not symptomatic, it's not going to be an active infection, so you're okay. Really, a lot of our complications of tuberculosis are respiratory related, so I would just again review those key hallmark signs and symptoms. For these patients, we end up putting them on what is called the RIPE method, and that's kind of a way I really like to describe this medication for these patients. They're going to be on a minimum of 3, if not all 4 of these drugs, and they're going to be taking them at the same time, okay? The whole reason of giving them various different types of meds is we want to resist drug-resistant tuberculosis. And remember, these drugs should be taken from about 3 to 6 months, and we want to stress the 90% adherence rule, meaning we aim for 100, we shoot for the stars, But really, realistically, 90% of the time we want that medication to be taken. So I would just review some of your nursing considerations for your RIPE drugs. For those of you that are taking notes, I'll talk a bit about it. Essentially, our rifampin, all of these drugs help to get our patient to have a negative sputum culture. But there's nursing considerations for each drug, which I would encourage you to review. Rifampin, that's the one that can turn our secretions orange. So we want to advise the patient of that. When we're talking about our isoniazid, I'm sorry if I butcher that, but when we're talking about isoniazid, this one can cause pretty bad liver damage. All of them can, but this one we want to look out for jaundice. And to reduce the risk of neuropathy, B6 intake, more vitamin B6. That's really going to help. With our pyrazamine, really we want to teach about photosensitivity, so practice safe sun, wearing sunscreens, long firm top, all of that. This can also worsen gout, so that's a good thing to look at. And when we're talking about health history, ethambutol, think E for eyes, okay? With these patients, they're at risk for optic neuritis, so we want to encourage frequent eye exams. I know you haven't learned about all these yet in pharmacology, but in a nutshell, those are some nursing considerations. Benjamin, you have a question? Okay, I saw your hand raised. If you want to type it out, go for it.
Sorry, I just joined actually, and I accidentally clicked the reactions thing, but you can go ahead. Okay. No question.
It's okay, no worries. If anyone has any questions, you can raise your hand or you can pop them in the chat. But so those are kind of like our drugs in a nutshell for those that haven't learned about it in pharmacology yet. Okay, again, we reviewed the isolation room for patient education. We want 3 negative sputum cultures before they can kind of go out. One thing I want to keep in mind is that if I'm living with my mom, dad, my brother, and my brother gets tuberculosis, I don't need to isolate if I've been living with them. Chances are I've already been exposed to it, okay? Also, no alcohol with these drugs. These drugs are very hard on the liver. You're taking a lot of meds for a long time. We don't want to throw alcohol into the mix, okay? We don't want to send them into liver failure, okay? Now we're going to talk about COPD. Do you need to test everyone in the household? So you won't at the moment need to test everyone in the household, okay? If we have one positive TB test, chances are everyone else has probably also been exposed to TB, so we can kind of rule that out because it's very like, I'm not sure if virulent is the right word, but it's very easy to be spread, okay? So there's no need at the moment to test those other people, but in the future, if they get a PPD test, it's probably going to show that they've had tuberculosis in the past. Okay, because remember, when we're differentiating active versus latent, these patients can't really spread the disease. So if they're not actively showing symptoms, does it really matter at the moment that they have latent TB? No, it's just going to be in their health history. But when we have that active infection, we do want to go ahead and follow up with that. So for COPD, I really want to reinforce, what is our patient's normal? What are some of the chronic symptoms, and how do we manage this? We'll talk about smoking cessation later on, but that's going to be a big portion of your COPD. So just to review, it is a combination of chronic bronchitis and emphysema. So they have all this inflammation in their bronchioles that kind of lead to that bronchoconstriction and mucus production. And then they have emphysema, which is hyperinflation of the lungs. So originally your lungs expand, contract. There's that nice elastic recoil. But with emphysema, I'm not having good recoil. So I'm having a really hard time exhaling. If I'm having a hard time exhaling, it means I might not be getting out all of my CO2. If you ever see that prolonged expiratory phase, that just means these patients have to exhale longer, and they do exhale longer because they have a hard time breathing out. They have a hard time getting out all that carbon dioxide, which is an acid. Therefore, they're doing it longer to try to get that acid out. And that's just the way the body compensates. So what will we see with these patients? Hypoxemia, which is their O2 sats usually are less than 90, between 88 and 92. They'll have hypercapnia, an increase in CO2, and that's just respiratory acidosis. Also, you might see some polycythemia, an increased hemoglobin and hematocrit. The reason that our red blood cells increase in number and size, and so do hemoglobin and hematocrit, our H's and H's are our oxygen-carrying proteins. So they kind of ride along the RBC to kind of grab onto oxygen wherever it's available, grab onto it, hold onto it, and then take it wherever it needs to go. So if my patient is used to being hypoxemic, the body's going to try to compensate so that in the event extra oxygen becomes available, that our red blood cells are ready to just pick it up, okay? That's why we're going to see that when we get their blood culture back. Risk factors, number one risk factor is going to be smoking. Could I explain the prolonged expiration a little bit more? Absolutely. So our body actually inhales and exhales on its own. It's part of like our autonomic nervous system. We don't think about it. We don't need to do it. So it's not necessarily that it's uncoordinated breathing. Our body is doing that on its own. The issue is these patients have what's called respiratory acidosis. So due to them holding on to that carbon, that CO2, they're going to have a acid-base imbalance, and that's that respiratory acidosis. So as the acid in our body builds and builds and builds, our body is pretty cool. It tries to fix the problem. So it fixes the problem by just having the patient have a prolonged expiratory phase. It's not that they're thinking about, I need to do this. That's just the way the body works, which is why when we teach them during exacerbations to do pursed lip breathing, we're reinforcing that concept. Okay? It's not necessarily a premature ending as much as their body's trying to get off that CO2. And that's just a body's natural response to getting off CO2. You breathe out CO2. When we talk about DKA in the future, that Kussmaul respirations, we're breathing out the acid. It's just what the body does. So again, we reviewed our laboratories. Really keep in mind, star it, highlight it, whatever you can. O2 sats range from 88 to 92, and they are perfectly comfy, okay? There's no need to try to put oxygen on them to bring it up to 95. They are happy as a clam between 88 and 92. Now, if they get to 80, that might be an issue, but 88 to 92 is very, very good. But assess your patient, assess for signs and symptoms of lack of oxygen, etc. Always assess your patients first. So what can we give them? We can give them our respiratory cocktail, if you will. Now, I know we haven't covered this in pharmacology yet, so I can talk a little bit more about it. Our beta-adrenergic agonists, these are albuterol and our salmeterol. Both of them work to open up the airway. However, albuterol is a short-acting beta-agonist. It's our SABA, meaning it has a very short onset. But what do we know about drugs with a short, onset? It means that they happen quickly, okay? They happen quickly, right away. So in an emergency, we always have to use our SABA first, okay? It's not going to work all day long, but in that emergency moment, it's great. It's going to be what's going to work the quickest. Once we give them their SABA, then we give them their LABA, their long-acting beta-agonist. So their salmeterol, that's going to help them throughout the day, and they take it every day. Same thing with our cholinergic agonists, our Spiriva, our beclomethasone. Beclomethasone is a steroid. Steroid reduce inflammation, which, remember, bronchitis, that's inflammation. So this Spiriva, the beclomethasone, the corticosteroids, the mucolytics, all of those are excellent for symptom management, and they help the patient really function on the day-to-day. And that's great because this is a chronic condition. But in the event of an emergency, always take your albuterol first, okay? Going to do no use if my airway is closed. If I start trying to inhale beclomethasone, mucolytics, blah, 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 it's not going to work. I need albuterol to open up the airway. So that way the rest of my meds can actually get in and do their job too. Make sense? Awesome. These patients are at risk for respiratory infections just due to all that mucus kind of building up. So we always need to get a CBC and sputum culture as well. And really high protein, high calorie diet is really good for these patients because they need about 3,500 calories a day because that's how much energy it takes for them simply just to breathe. Okay? Pursed breathing, diaphragmatic breathing are very good, and as always, smoking cessation, which we will review later. So obstructive sleep apnea. We're going to review some of the concepts of ABGs, some risk factors, treatment do's and don'ts, and narcolepsy. So what's happening with obstructive sleep apnea? Well, similar to COPD, it's that respiratory acidosis. So what happens at night is these patients go to sleep. And due to whether it be obesity, large kind of vulva, tonsils, short neck, edema, whatever the case may be, during sleep, something falls into the airway and their airway gets blocked off. They can't take a breath in, they can't take a breath out. So what happens? My carbon dioxide begins to build up. So now I'm pretty acidotic. Well, the body doesn't like that. So my body is going to wake itself up. The patient's going to wake up. They're going to take a breath, and they're not going to know what happened because it's during sleep. They wake up, go right back to bed. This happens about 5 times an hour. So they're not getting a good night's sleep. They're having sleep deprivation, and there's so many negative health outcomes associated with sleep deprivation, but specifically we're really concerned about narcolepsy. Okay, that's excessive daytime sleepiness. That means that maybe it's not the safest for these patients to be driving a car. What if they fall asleep behind the wheel? What if they fall asleep behind the truck at work? Really something we have to talk about, and there's one medication we can give to help with that. Okay, overnight sleep study is going to be the best way to diagnose. When we're talking about symptoms, though, usually it's the patient's partner, roommate, sibling, mom, whatever, that comes in and says he snores a lot, he gets up at night, etc. And then you're going to see a lot of those symptoms of just lack of sleep. So what can we give? We can give modafinil. This will help promote daytime wakefulness. Now, it doesn't treat the cause or anything like that, but it's going to help these patients stay awake during the day. Okay? So how do we fix this? Well, we're going to give them oxygen during bedtime. There's loads of different ways you can review the different types of masks, but our CPAP mask is the most common, okay? It's the mask that goes around the face. They sleep with it. All it does is it provides continuous airflow through the mouth and nose down to the lungs. This keeps the airway open, okay? What don't we want to do? We don't want to give our patient food before bed because they could aspirate. Additionally, we do not want to give them any CNS depressants, okay? Anything that may make them drowsy, tired, etc. Alcohol is a depressant, anything like that, we really need to avoid. Why? The only thing that's essentially saving these patients from lack of oxygen during their sleep is the body waking itself up. But if we give a depressant and we suppress my body's, normal reaction, they're not going to be able to wake up, okay? And that's a really big problem, okay? So I have 2 practice questions for you guys. Let's start with number 5. Please put your answer in the chat and we'll go over the rationales. So the first one, a patient is newly diagnosed with COPD due to chronic bronchitis. You're providing education to the patient about the disease process. What statement by the patient indicates they understood your teaching about this condition? What do we think about this one? A, B, C, or D? Awesome. Good job, guys. It's B. We know that these patients are at risk for pulmonary hypertension and right-sided heart failure, okay? Why are they at risk for right-sided heart failure? Where does the right side of the heart go? It goes to the lungs. If I have an issue with my lungs and my pulmonary circulation, that's going to cause all that blood to back up into the right side of my heart. That leads to that heart failure, okay? You may also hear right-sided heart failure from pulmonary hypertension as cor pulmonale, just so you're familiar with that. Let's do number 6. An alarm beeps notifying you that one of your patient's oxygen saturation is reading 89%. You arrive to the patient's room and see the patient comfortably resting in bed, watching TV. The patient's already on 2 liters of oxygen. The patient is admitted for COPD exacerbation. Your next nursing intervention would be, what do you guys think? Absolutely. Continue to monitor your patient, okay? Even if this patient, I don't know, maybe you don't even know the history on this, you always have to assess your patient first. Are they showing signs and symptoms of decreased oxygen saturation? Are they showing signs and symptoms of hypoxemia? Well, we're going to assess my patient. If they're alert and oriented and they're answering your questions, that means that there's blood flow to the oxygen, there's oxygen to the brain. So that's great. You can also look, are they blue in the lips? Are they blue in the fingers? What's happening? So we always assess our patient first. But what we do know about COPD is that's a normal finding for them, okay? But always assess your patient. We don't want to hyperoxygenate. I have another one. A patient with severe COPD is having an episode of extreme shortness of breath and requests their inhaler. What type of inhaler ordered by the physician would provide the fastest relief? Excellent. Albuterol. Albuterol is our short-acting beta agonist. It acts fast. Wonderful. Love the answers. Beautiful. Let's do 9. Which of the following statements are incorrect about discharge teaching that you would provide to a patient with COPD? Select all that apply. So there's more than one right answer. Okay? What statements, and this is how NCLEX likes to word them, they might say, what statements require further teaching, or what requires follow-up? So of all these, what's just wrong? What's just not right? Awesome. I see lots of A's. Good job, guys. It's A and C. With A, we usually want about 4 to 6 small meals that are high in calorie, high in protein, that are like easy for the patient to eat. So peanut butter's foods similar to peanut butter are good because a lot of protein, a lot of calories in not a lot of food, if that makes sense. Because these patients get very short of breath while eating. We don't want them eating a giant, humongous meal. They're going to get very, very tired. Also, it's important they receive the pneumonia vaccine because these patients are at increased risk for pneumonia. Okay, remember all that mucus, possible infection, they have a hard time coughing, all of that stuff. Now, the other ones are incorrect. Smoking cessation will not improve their symptoms, but it will prevent them from getting worse, okay? Oh, sorry. No, you're right. I thought that was the incorrect choice. Smoking cessation can help, like, improve, like, their shortness of breath and stuff like that. Forget what I said. I'm thinking of, I know what I'm thinking of. I'm thinking of something else that's not related to this. I'm thinking of coronary artery disease or something. But good job. So it's going to be A and C. Thank you. Okay. Some questions on tuberculosis. Your patient is diagnosed with a latent tuberculosis infection. Select all the correct statements that reflect this condition. Would the pneumovax be beneficial for this patient because they are at risk? Let me check. Oh, I see where you're coming from. I will get back to you on that. I have the rationales, I think, at the end of this PowerPoint. So we'll review the rationale. I believe so. I think you're supposed to get it more frequently than annually. Yeah, I don't think that Pneumovax is annually. I can double check for you. I apologize for that one. I should have put the rationales right after, but I threw them all at the end. Yeah. These patients, you would probably advocate that they get like a flu shot annually as well. But I will get you guys the rationales, I promise. So our patient is diagnosed with a latent TB infection. Select all the correct statements that reflect this condition. So now we're switching from COPD, we're switching to TB. So which of these are correct about latent TB? What's correct about latent TB? That's okay. Give it your best shot. Awesome job, guys. So the correct answer is going to be A, B, and C. And I just pulled up my rationales on my little Google Doc for you guys. So A is correct. They don't need treatment if it is latent TB, okay? The patient is not contagious and will have no signs and symptoms. That is true. They will have a positive PPD test. That will not be an abnormal x-ray. You'll just see a lesion. When you see that abnormal ground glass, like crazy looking x-ray, that is our active TB. A lesion wouldn't qualify as like an abnormal chest x-ray. If someone has like a really abnormal ground glass, very cloudy looking x-ray, that's how we know it's active, okay? So it's just kind of comparing, like the active one is the abnormal chest x-ray, okay? And then the sputum, you won't test positive if you're latent in your sputum, okay? All right, let's do number 7. A 52-year-old patient is receiving medical treatment for a possible TB infection. The patient is a U.S. resident but grew up in a foreign country. She reports that as a child, she received the BCG vaccine. What physician's order below would require the nurse to ask the doctor for further clarification? And I think this one was in a really small spot on your pre-class worksheet. Great job, guys. It's A. That's why our chest x-ray, our QFT, our sputum are all really good options for testing an active TB infection or any sort of TB infection, because remember, there's a couple different other things that can kind of get in the way of a PPD test, okay? Some false positives, if you will. But yeah, specifically our BCG vaccine. The reason that TB tests are so common in America is we really don't give the BCG vaccine over here. But other countries, they do. So that's the rationale behind that one. So now we're going to talk about allergies. And as always, if you have any questions or if I'm going too fast, please let me know. Pop it in the chat, okay? So we're going to review some basic types of allergies. Specifically, we want to focus on some medical emergencies and symptom management. And then we'll talk a little bit about a decongestant medication that we need to know about. Okay? Not super important to know the patho behind allergies, but again, this is for you guys if you do need help. Just remember, there's many different ways an allergen can be gotten, I guess. It can be inhaled, ingested, injected, absorbed, contacted, all of it. And symptoms really do range in severity. You have your traditional runny nose, itchy, watery eyes, not a priority, that's just normal. And then you can have emergency situations. So what are some emergency situations? Anaphylaxis leads to hypotension, absolute emergency. Facial swelling such as angioedema and hives. Those are very scary and they require epinephrine to help. Okay? You can give some supportive treatments. There's many different times. Decongestant nasal sprays aren't really used much anymore because they have a really bad rebound effect if you've used them, longer than you should. Meaning that you've taken them for a week and then you stop and now your nose is running like Niagara Falls. Okay. Other different things we can use, not super important. The best way though that we can treat and manage our allergies is going to be avoiding the allergen altogether. Okay. Medications are not 100% effective and there are risks with all medications. The one way that we can, guarantee that these patients are not going to have like allergies or allergic reactions is by avoiding what triggers them. If they don't know their trigger, encourage them to keep a journal because that's going to be the best way to treat and manage allergies. So now we're going to talk about asthma. Again, we're going to prioritize meds and review some proper inhaler care. So essentially what happens with asthma is there's a hyper-responsiveness within the upper airways to a trigger. This causes lots of swelling that interferes with the blood flow and gas exchange, okay? Signs and symptoms are going to have a really bad wheeze. It can be inspiratory or expiratory, but more common you're going to see that wheeze on exhalation. I do want to keep in mind, though, if you are hearing a wheeze and then you auscultate 5 minutes later and you don't hear a wheeze, it doesn't mean the patient's getting better. It means they're getting worse, okay? This means that their airway has completely closed off and you have a medical emergency. However, if you gave them medication and you know you've given them medication and you don't hear a wheeze, then that's good. But if you didn't give meds and now you don't hear anything, it's an emergency at this point, okay? What we do as nurses is we assess their PEFR, okay? We also teach our patients how to assess their PEFR by themselves when they are at home. So there's your red, yellow, and green zone. This is going to help us figure out what medication to give these patients and how we can best help them, okay? So when someone is in the red zone, it means that they are functioning at 50% or less of their normal best capacity. We need emergency drugs. Yellow, that kind of ranges, and then green. But all of this is based off of what a patient's baseline is. But just know that if we're kind of in that red or yellow zone, we need to administer meds fast, specifically our rescue inhaler. We reviewed albuterol, that's our rescue inhaler, okay? And frequently do respiratory assessments. Always teach your patient, you always need to be carrying your rescue inhaler. If you don't have your rescue inhaler, you really should be carrying it because in an emergency, your Spiriva is not going to help you. Your albuterol will. So I have a NGN practice question. I know these are a little bit difficult, but we just want to work through it, okay? You will see these on boards. This is the new style, and you might also see them on exams because professors are trying to prepare you guys best for boards and incorporate NGN questions. So if you ever see something that's indicated, contraindicated, or non-essential, when it says indicated, that means, yes, we need this. It's appropriate for the situation. If you ever see contraindicated, this means that this could potentially harm the patient, and we should not do that, okay? This is associated with something negative. Now, non-essential means you could do it, you couldn't do it, it's just not pertinent at this moment or to this situation. So you have to look at the prompt, you have to look at the question, and you have to ask yourself, what's this question asking me? I don't really know what this question's asking me. So that's what you got to do. So after looking at this question, what do we think is going on once we review the prompt? What do you guys think this question's asking us about? We got a lot of information. We have to narrow it down because it's going to help us figure out what non-essential would be. So you guys can read it, but what do you think is going on? You have someone that came in the ED after a car crash, okay? He is in quite a bit of pain. And in addition to his pain, he has low-grade fever. And for the past 4 months, he's had a lot of fatigue, lethargy, night sweats, and a bloody cough. What do you guys think is going on with this patient? It's okay if you don't know. What do you think? Pop it in the chat. Absolutely, guys. I'm thinking tuberculosis. I'm seeing this night sweats, bloody cough for 4 months. It's not a simple infection. It's not going away easily. So this question's asking us about tuberculosis. So think about that when we're answering indicated, contraindicated, or non-essential. So let's do number 1. Do you think that it is indicated, contraindicated, or non-essential? Should we notify the surgeon and the OR immediately? Good job, guys. It is going to be indicated for this patient. And not to fear, I have the full rationales on the next slide for you. What do we think about administering prescribed medication? Prescribed pain medication, what do we think? Look at what was in our assessment. What was in our notes? Absolutely. He's rating his pain at an 8 out of 10. He has fractured a bone. He's fractured his leg. He's in a lot of pain. We don't want to keep him in pain. What do we think about making the family leave the client's room? Do you think that's indicated, contraindicated, or non-essential? What do we think? So, I see lots of non-essentials. Non-essential does not mean, oh, we don't have to do this for the situation. What non-essential means is that it's not pertinent to like the situation, if that makes sense. So there's a better option. And that's kind of what NCLEX is. What's the best option? So it's actually contraindicated. The reason it's contraindicated is because this patient is in a lot of pain. He's in the ER. He's probably scared, okay? It would cause more distress to both him and the family to force them to leave, okay? We also know that he's been living with this for 4 months. They've probably already been exposed, okay? So that's why it's contraindicated. The full rationale is on the next slide. Should we place a mask on the client? What do we think about that? Yep, it's going to be indicated. I know we skip the nutrition question every time. I'm so sorry. We'll go back to it. I know. I don't know what it is. This is the 3rd session I've done. We skipped it every time. But yeah, it's indicated. You're in the ED. You're going to be transported. He's not yet in an isolated negative pressure room. We do want to do that. What about collaborating with the nutritionist? What do we think about that? Very good. I like that one. Very, very good. It's not essential. All of our patients meet with a registered dietitian. Not really important right now. Has nothing. Nutrition, TB, not associated. What about asking the family to wear masks while in the client's room? And this one, again, it can be a little bit tricky. Yeah, this one's non-essential. It doesn't make a difference. We don't have any reason in which it would be necessary for them because they've been living with him, and we have no evidence that it would harm them at all. So it's non-essential. What about performing the TB test on the client? Yep, that's indicated. What about the family? This one is non-essential, and I do want to reiterate the reason. The reason is because it will most likely test positive if our patient is positive, but also the family are not currently clients in the hospital. They're not our patient, okay? We're not authorized to give someone that's not our patient test, okay? What about reporting the possible TB infection? This one's tricky. Correct. It's not confirmed yet. We don't have a confirmatory diagnosis. I'm not going to call the CDC and say, hey, I think my patient might have TB, but like I'll follow up. They'll say, well, why are you calling me? That's what they're going to do. Also, it is not the responsibility of the nurse to report that. It is, I don't know who it is. Someone else will call it into the health department. You don't report it to the health department. You report it to like the hospital, the management, and then they take care of it. As you can see at the bottom. And these are from ETI, so they give really, really good rationales. All right, we have one more of these fun little case studies. We have a 24-year-old female client coming to the ED with an asthma attack. She's had them frequently. She's now on a plan. On admission, she has audible wheezes on inhalation and exhalation, and her pulmonary function tests are 40% low than her best, so 60% of normal. It gives you her vital signs. Upon further assessment, she has suprasternal and intercostal retractions. She can speak 4 to 5 words and states she's frightened. Her asthma management includes these drugs. So we give her meds. We help make her comfy. We give her oxygen. And 10 minutes go by and we reassess. The reassessment findings are on the right. So, based on these assessment findings, do we think that our treatment was effective, meaning it worked, ineffective, meaning it didn't work, or unrelated, meaning it's kind of like that dietitian. Is it really important right now? So, is it important to the situation? So this question's asking us about asthma. What do we think about having wheezing present on exhalation only? Good job, guys. It was effective. So we're looking at trends, and trends are a really big concept in our complex health nursing one, and they're really big concepts on tests. We look at the trends. She still has wheezes, yes, but they're getting better, okay? What about a temperature? What do we think about that? Good job, guys. It's unrelated, okay? Temperature's really not related to asthma at all. What do we think about her function tests being 70% of normal? What do we think about that? Awesome. Effective. Very good. They went from 60 of normal to 70 of normal. We're doing great. My client states she's frightened. And if you ever have any of these where you're confused, you're like, maybe it worked, maybe it didn't work, look back to your data. Always look back to your data. Good job, guys. We know that it's ineffective. How do we know it's ineffective? If we look at our assessment, she stated that she was frightened. We reassessed. She is still frightened, meaning we haven't calmed her anxiety, we haven't calmed her nerves, all that stuff. So that's how we know that that one's ineffective and not unrelated. It was in the notes. What about a blood pressure of 152 over 100? What are we thinking about that? What do we think about blood pressure? I see we're pretty split between ineffective and unrelated. So I actually asked my clinical instructor about this because ATI didn't give me this rationale. So I asked my instructor. So number one, obviously asthma is not really associated with blood pressure, okay? Nothing we learned about in class had anything to do with BP. That's how we know it's unrelated. He also told me a little bit that that's actually an expected finding of asthma medications. They will increase your blood pressure a little bit, specifically like our corticosteroids and whatnot. But just know that, does asthma have anything to do with blood pressure? It doesn't. If we go back to the basic roots of patho, it does not. What do we think about her oxygen sats of 86? Awesome, effective. We're going up. We're not where we want to be, but it's only been 10 minutes and she's only had one treatment. We're moving in a good direction and that's all we care about. What do we think about respirations, 30 breaths per minute? Awesome. Trends. We're going in the right direction. Great job. And finally, or not finally, a pulse of 130 beats per minute. So this one's unrelated again, even though it was like in the data a little bit. Does pulse rate and blood pressure, they kind of go hand in hand. It's the same concept. Do heart rate and blood pressure at the root of patho have anything to do with asthma? No. There can be many different causes. There's over hundreds of causes of increased heart rate. Can we link it to asthma? We can't. So that's how we can kind of tell it's unrelated. What about no retractions being visible? Awesome. Great. We had retractions, now we don't. We're doing great. Awesome job, guys. So again, here's some of the answers. I don't know why, but there just simply wasn't a rationale for this. So I did have to consult some higher ups for y'all. This is more of your traditional NCLEX question. So this is talking about asthma. So again, I lined out some asthma stuff at the top. So patient with asthma comes to the clinic complaining of difficulty breathing, chest tightness, and coughing. His flow measurements are 50% of normal and his O2 sats are 92. What's the appropriate nursing action for this patient? Awesome. We give them their neb treatment with albuterol and ipratropium. We see albuterol. That's great. That's going to open up the airway so that their ipratropium can get in. That's just another same type of med as Spiriva. Great job, guys. So now we're going to switch from the lungs to the brain. So now we're going to talk about neurological disorders. The first one we're going to talk about is Parkinson's. Really, it's important to know what are the neurotransmitter issues. Once you know the neurotransmitter issues, it helps us treat it, okay? It's going to make our meds make a lot more sense because I know we haven't talked about them yet in Pharm. Hallmark signs and symptoms and some nursing considerations and priority diagnosis. So what's happening with Parkinson's? Well, we don't necessarily know the cause. All we know that something's causing a drastic decrease in dopamine. But what happens when we drop our dopamine? Our acetylcholine will increase. They're like two little balances on a seesaw, okay? When one goes down, the other goes up. That's how we can differentiate Parkinson's from some other neuro diseases. Okay, so this increase in acetylcholine throws our body out of whack, okay? Therefore, our treatment is going to focus on increasing our dopamine and decreasing our acetylcholine. So what are our hallmark signs and symptoms? These you're going to have to know. Specifically, your pin-rolling tremors, your muscle rigidity, drooling, cogwheel movements, bradykinesia. They're just going to be moving very slow, have some shuffling, etc. So what drugs can we do? So we talked about what we need to do in terms of our neurotransmitter levels. So what drugs help us do that? Our levodopa, carbidopa. That's our drug of choice. So this drug needs to act on the brain, but we have what's called the blood-brain barrier, which doesn't allow much to get past it. So we like to do a combo drug of our levodopa and our carbidopa, also called cinnamon. So I like to describe it as the levodopa goes on the car to cross the blood-brain barrier, okay? So the car takes it through the blood-brain barrier. Our carbidopa takes it through the blood-brain barrier, allowing the levodopa to get where it needs to go, okay? So the levodopa can act on the brain. We can also give them anticholinergic medications because why? We want to decrease acetylcholine. How do we do that? Anticholinergics. Cool. One thing you do need to know about your anticholinergics is these are your dry drugs. They dry you up. So you're going to have urinary retention, dry mouth, dry skin, all the dries. So just think of your nursing considerations for that. Maybe giving them some ice chips to suck on, staying hydrated, etc. There's some other meds to know, so you can review them a little bit, but your first two are your most common. What do we need from these patients? Well, if they're in the hospital with us and we've never really assessed them before, we need to get a swallow study done. Why? We need to make sure that they can swallow their meds, that they can swallow food. Because remember, the dysphagia, that's a really big issue. If you have dysphagia, you're at risk for choking, at risk for aspiration pneumonia. It's not good. And you'll see that as a common reoccurring theme for a lot of these neuromuscular neuro disorders, okay? Patients are also a fall risk. Back to that aspiration, we put them on aspiration precautions, meaning we keep the head of the bed elevated and we always have suction at the bedside. To help them in their day-to-day, we can teach them chin tuck swallowing. That one is really, really good for these patients. Rock a few times before getting up, march for the freezing gait, lots of patient education. Now we're going to talk about Huntington's. So Huntington's is kind of the opposite. We now have too much dopamine and not enough acetylcholine. What we do know about Huntington's is we know the cause. It is an autosomal dominant genetic disease. And if we go back a slide, if you have Huntington's, you have about a 50% chance of passing it on to your child. So this causes a major ethical issue and a really difficult decision for parents when they're talking about family planning. Okay. So what are we going to do for these patients? Well, we're going to assess their signs and symptoms. They're going to have coriform movements, progressive dementia, again, difficulty swallowing. So implement your aspiration precautions. Get a bedside swallow study done. Unfortunately for Huntington's, there's no cause. Sorry, not no cause. There's no cure. What we can do is we can give them antichorias, but that's just more symptom management. It helps with their coriform movements. And treatment just helps to alleviate the symptoms. Unfortunately, once symptoms have their onset, which is usually around like maybe 30 years of age, there's about an average of 8 to 10 years life expectancy past the onset of symptoms. So that's something you need to keep in mind. So we need to plan for residential, end of life care, etc. We've already talked about all of our aspiration risks. What makes Parkinson's and Huntington's so fatal? Excellent question. So two different things. With Parkinson's disease, if we go back, remember, Parkinson's can kind of be associated with kind of under the branch of Alzheimer's. So really what makes Parkinson's so fatal, they're going to have lots of mobility issues. And we know that past a certain age, falls, broken bones have a very high mortality rate due to like fat embolus syndrome. They don't heal as well. A lot of hazards of immobility if you're not moving as much and you're stuck in the bed, pneumonia, respiratory complications, all of the things like that. So when we're talking more about Parkinson's, it's more of your hazards of mobility, consequences of immobility, aspiration, etc. Again, a bit more of our like cognitive decline. So usually more unsafe scenario. Yes, so increased risk for infection, absolutely, specifically in the lungs. Pneumonia is usually the most common cause of death in patients with issues like these. Again, with Huntington's, it's the same thing. So essentially, we have difficulties with swallowing, which lead to malnutrition. We also have severe muscle wasting and weakness. So eventually these patients have very progressive dementia. They end up being bedbound, and that leads to, again, pneumonia, aspiration, death, things like that. So lots of respiratory issues, okay? And it'll make more sense when we also talk a little bit more about ALS. But yeah, the cause of death for like our Parkinson's and Huntington's, you don't necessarily die from Huntington's, you die from the complications due to Huntington's. Same thing with Parkinson's. You die to complications due to your Parkinson's disease, because Parkinson's puts you at an increased risk for, you know, everything I just said. I hope that helped. Okay. Oops. Going back. So, practice question. A patient with Parkinson's disease has slow movements that affect their swallowing, facial expression, and ability to coordinate movement. As the nurse, you will document that this patient has, what do they have? And for D, I forgot tremors, but just pretend that that would say pinrolling tremors. Awesome job, guys. Bradykinesia. If you ever see the word Brady, that means slow. So kind of knowing the med terminology helps a lot. Student number 6. You're providing free education to a local community group about the signs and symptoms of Parkinson's disease. Select all the signs and symptoms a patient could experience with this disease. So what are some signs and symptoms of Parkinson's? What are we thinking? I know there's a lot. Okay. Cool. All right, we'll go down the line. So they don't have increased salivation. That's not part of Parkinson's. Yes, they're at risk for aspiration, but it's not really due to like that excessive increased salivation. They do have lots of drooling though. So I would definitely give that to you guys. But they do have like that increased incidence of drooling, but it's not because they're producing excess saliva. It's simply because they lost muscle function of the mouth, if that makes sense. These patients also are not going to have loss of smell. They may have constipation associated with just like the anticholinergic medications. They do not have tremors with purposeful movement. It is just they're pinrolling tremors, so they're with non-purposeful movement, if that makes sense. They do have a shuffling gait. They do have that freezing of the extremities, and they do have coordination issues. So for these patients, they would actually have, if you kind of go down, they would have C, E, F, and H. Again, these questions from NCLEX, they also take into consideration pharmacology, so that constipation comes from the pharmacology of anticholinergics. But you guys did really good for not learning about the farm stuff yet, so very proud. Yep, and just to reiterate one, it is drooling, not increased salivation. They're physically not producing like extra saliva, they just have no control over their mouth muscles. That's what's causing the drooling. All right, so now we're going to switch to multiple sclerosis. We're going to review hallmark signs and symptoms, some immunosuppressant considerations, and why they might be on immunosuppressants, and some sensory concerns. So lots of information on this slide, but we will break it down, no worries. So essentially what's happening with multiple sclerosis is my immune system is attacking the myelin sheaths on my nerves, and a little bit of patho behind myelin sheaths. Think of a road that is nice and smooth. I can gas my car 50 miles an hour over it, no problem. I can get from point A to point B pretty darn quickly. But let's say I have a lot of potholes in that road. To get from point A to point B, it's going to take a little bit of extra time, and it's not going to be as nice, smooth, and coordinated. That's the same concept with multiple sclerosis. We have so many plaques on these myelin sheaths. Myelin sheaths help send the nerve impulse from point A to point B. So lots of issues with that mind to muscle connection, okay? Remember though, our brain, spinal cord, and our nerves, they don't regenerate. They don't heal themselves. So once the damage is done, it's done. That's why no matter what the cause is, once you have an exacerbation, you're not going to go back to baseline function because the damage is done. We can't fix it. Okay? Lots of different signs and symptoms. Specifically are diplopia and sarcomas, which are blind patches. These patients have a lot of eye issues, so we can actually encourage them to wear like eye patches, things like that. That might help. Utoph sign is very common. They're going to have issues with perception, sensory perception, all that types of stuff. Urinary retention and constipation, again, it's due to that mind to muscle connection where my mind is trying to tell my bladder, hey, are you feeling full? It's time to empty. Well, number one, my bladder's having a hard time with sensing if it's full or not full, and my brain's having a hard time telling my bladder to empty. So just lots of sensory and muscle perception issues. The bladder is very common for multiple sclerosis as well. Okay. So remember, lots of plaques. In a lumbar puncture, you'll see a lot of immunoglobulins and proteins in the CSF, which usually aren't there. If you ever get the opportunity to see a lumbar puncture done, what is nice and good for lumbar puncture is nice and clear. If it's a different color, if it's cloudy, we know that something else might be in there. That's probably not supposed to be there. What can we give for these patients? We can give them immunomodulators. interferon. If you ever see like kind of the ending, like infliximab or like UMAB, those are pretty indicative of like a medication that works on the immune system. Immunosuppressants are the most common for these patients, specifically corticosteroids. They are a drug of choice, okay? We just want to be cautious of Cushing's syndrome. And then muscle relaxers help because, again, with that myelin sheath destruction, we have lots of muscle rigidity because we're having a hard time telling our muscles to relax. But our goal for these patients, we know it's an autoimmune disease. We treat autoimmune diseases by suppressing the immune system. If that's the cause, well, we fix a problem by identifying and fixing the cause. So our main priority concern for multiple sclerosis patient, aside from assessing the sensory issues, they're on immunosuppressants. How do we keep these patients safe on immunosuppressants? And I guarantee you that's going to be testable material. So what can we do? Teach them to remain free of infection. No large crowds. Maybe now's not the time to go in a mosh pit at the concert. Probably not the best time. We don't really want them planting in the garden, not around the sick kids, just a bunch of things like that. Okay, so really review your immunosuppressant stuff. So now we're going to talk about ALS. We're going to talk about our priority concern and some interventions. So really what happens with ALS, not super important to know all the patho behind it, but just know that our brain and our body can't communicate anymore because of this destruction that occurs in both the upper and lower motor neurons. Okay? This leads to a loss of voluntary muscle control, which leads to muscle weakness and complete paralysis. Usually death is within 5 years from the onset of symptoms. The way I describe this is you essentially have total body paralysis that starts from the fingers and the toes, and it slowly creeps inward up the body. Once it hits the lungs and my lungs are paralyzed, I can't breathe anymore on my own, and that is what these patients usually die from, if not some other complications as well. So really, you'll start to see some fasciculations in these patients. They'll start having really bad muscle atrophy and weakness. And while there is no definitive cause, we assess the symptoms and we just rule out everything else. Again, dysphagia, think swallowing, aspiration. These patients usually will be put, they will have a G tube put in place and their feeds will be done directly into their stomach, okay? Because they're not going to be able to swallow or chew or anything like that. Okay, so they'll have this weakness, which progresses to spasticity, then like hyperactive reflexes, and then no reflexes at all. It's important to know about this disease. It's not a disease of the mind, so their mind doesn't get affected in the same way that Parkinsons and Huntingtons kind of have that neurocognitive decline. That doesn't happen in ALS. So these patients are completely aware of everything that's happening to them. So it is a very scary disease for them. There is no cure. We really do team management, working with nutrition, occupational therapy, all of that for these patients. We can give them riluzole or Endarvone. Again, these help to slow the progression, but you're not slowing the progression by 10 years. You're slowing the progression by maybe 2 years at best, okay? Really, these patients do require around-the-clock care, so whether they have a home health nurse or they're living kind of like a palliative care unit, palliative care hospice situation, that's what these patients are going to need. So yeah, you really need to just have those difficult discussions early on, okay? So now we're going to do some more practice questions. So a patient is suspected of having multiple sclerosis. The neurologist orders various tests. The MRI results are back and show lesions on the cerebellum and optic nerve. What signs and symptoms below would correlate with this MRI finding in a patient with multiple sclerosis? So we have some lesions. on the brain and the optic nerve. Okay. So what do these lesions do? The lesions are the destroyed plaques. So if I've got damage to my cerebellum and my optic nerve, what do you think the patient is going to present like? And remember, like, the function of the cerebellum as well. Those are our complex motor functions. What are we thinking? I see you guys are on the right track. Very good. So yes, you are going to have blurry vision. Because this is on the optic nerve also like is a big sensory nerve to the eye. So they are going to have a little bit of pain with moving the eyes. That's just because due to the location of the optic nerve. So I know that can be a little bit difficult, a little bit more advanced. So not to worry. C is also correct. Difficulties kind of with speaking, things like that. Again, we got some plaques in the brain. We're having a little bit of a harder time. And they will also have their balance and coordination issues. That's what the function of the cerebellum is. And finally, they will have dark spots in vision. They don't necessarily have heat intolerance. It's more of an activity intolerance. So when they have those, the temporary worsening of their vision, that's during activity. Okay? But good job, guys. But like that UTOF sign, that's activity. Okay? So now we're developing a plan of care for a patient with multiple sclerosis who presents with UTOF sign. So we talked a little bit about it. What interventions will we include in their plan of care? Select all that apply. Yep, B and C. Very good. So with these patients, we probably don't want them to, what's the word I'm looking for? Like HIIT workouts, probably not the best for these patients, but swimming, water aerobics, those are like our drug of choice for these patients. It's actually B and D. B and D. Warm packs and heating pads don't really help for those symptoms of UTOF sign. It is D. It's B and D for number 10. So it's what are we including in their plan of care? Yep, B and D. So we're going to tell them how to avoid overheating during exercise. We're going to keep the temperature cool. And really what's happening with these patients is that when they're very active, they're overheating. And that's kind of where you see kind of with question 4, where it's heat intolerance. It's not that them being like it in Florida being hot. It's that when they're exercising, their heart rate up, their internal body temperature goes up, and that's kind of what the issue is. But good job. Very good, guys. So I have another question. 38-year-old patient has been diagnosed with ALS and subsequently has developed breathing difficulties, including shortness of breath and an inability to cough. What best describes a nutritional change associated with this? Good job, guys. Dysphagia, difficulty swallowing. Great job. So now I believe the last disease we're going to talk about, well, disorder, it's going to be migraines. So migraines are very, very basic. What medication can help and what patient-centered care do we need to do? So there's lots of different causes of migraines. I wouldn't recommend having to know every single type, cause, whatever. Just know that some migraines are normal with patients. They just might have a history of migraines. Usually your patients might have an aura and they can kind of sense and feel when that's coming on. But again, it's tailored to the patient. But most of them present with signs and symptoms of photophobia, nausea and vomiting, and a unilateral pulsating pain. So it's like they have pain in like one specific area that's just pulsating. So again, similar to asthma, allergies, we avoid the triggers. If they know that they usually get migraines from heavy perfume, avoid wearing perfume, things like that. We can also do some abortive therapies if the migraine is coming on, or let's say it's just been going on for 4 days. Usually that's when these patients will come to the ER if they've had a 4-day long migraine. So we can give them sumatriptan. That can really help abort their ongoing migraine. Okay? So really, we place the patient in a cool, quiet room. This is our patient care. We're going to cluster our care. Okay, we're going to do blocked care. We're not going to be in there every 5 minutes doing something. We're going to leave them alone. We're going to elevate the head of the bed. We're going to keep it nice, cool, quiet, give them an ice pack, manage their pain, and let them rest. Okay. Now we're going to talk about SLE. We're going to talk about major complications due to inflammation, signs and symptoms, and some medication considerations. So what happens with SLE, this is another autoimmune inflammatory disorder. What happens with SLE is my body produces, for whatever reason, my body produces immune complexes that deposit everywhere in my body, okay? Anywhere and everywhere. What happens when an immune complex deposits somewhere, it attracts immune system cells to go fight it. So what happens is if these immune complexes deposit in the organs, it can lead to organ damage and thus organ failure. Okay. Signs and symptoms, they'll have an inflamed red butterfly rash, very, very dry skin, okay, Raynaud's phenomenon, painful swollen joints. Usually SLE is associated with our rheumatoid arthritis. So yeah, what I would know is that lots of exacerbations can have different causes. Our number one cause is going to be the sun, and with women, it's going to be childbirth. So just review that. So maybe teaching these patients, practice safe sun. Wear your sunscreen, don't be outside for too long sleeves, big hat, whole 9 yards. Okay, so again, we're going to suppress the immune system. If the immune system is causing the disease, how do we treat the disease? Well, we address the cause. We're going to suppress our immune system. So we can give them prednisone. Again, steroids are very good immunosuppressants. Remember those immunosuppressives I talked about that ended in the UMAB? Those are immunosuppressants. Teach your patients, no live vaccines, okay? For rheumatoid arthritis, hydroxychloroquine is a drug of choice. So yeah, so again, lots and lots of patient education. And a lot of it is tailored to immunosuppressive therapy. So if you have an increased fever, that's very important to report to your provider because you are at increased risk for infection, and that's not good. Rest during exacerbations, you're going to want to protect the skin, avoid drying agents, and avoid ill individuals, okay? We do want to do some full assessments. We want to assess their BUN and their creatinine to look at their kidney function. Why do we do this? Well, if I have some immune complexes that deposited in my kidneys and my body attacked my kidneys, it might put me in kidney failure and I'll see a decline in kidney function, okay? So we do your full assessments on all the systems, our integumentary, our skin, whole 9 yards. So I have a practice question for you guys. A patient with SLE is experiencing a complication called lupus nephritis. Whenever you see nephro, think kidneys, okay? What are some signs and symptoms that correlate with this complication of SLE? What do we think about this? What do we think? It says select all that apply. And I know lab values just love to be tested on. So for these patients, you are going to see an increase in BUN. You are going to see a 48-hour urinary output of 720 milliliters. That's 2 days. You're only producing 720 milliliters. That's a problem. We've all seen the 500 cc syringes in the hospital. That's not even 2 of those. So that's pretty indicative my kidneys aren't working too well to excrete my urine. You'll also see proteinuria. Protein is not supposed to be found in the urine. That's because the kidneys filter it out. If my kidneys aren't filtering it out, it's going to be excreted in my urine. And finally, you're going to see lots of edema, okay? Other things you might see, you will see an increase in creatinine. You'll see an increase in weight, okay? You're providing education to an SLE support group about preventing flares. Which statement by a participant requires re-education about this topic? You might also see NCLEX word this as, which of the following statements indicates a need for further teaching? Yep, awesome. So with SLE, we still want to encourage physical activity, but we're going to tailor it to the patient. We still need to be active. We still need to be working out our bodies. But again, like I said, water aerobics is probably pretty good for these patients. Walks early in the morning, yoga, things like that. Great job, guys. So I have another one of these: effective, ineffective, unrelated. So you guys know the drill. We're caring for a patient with Parkinsons. He's on multiple drug treatments. He lives at home. He just doesn't drive. He visits his primary health provider for his usual annual physical. So this is an annual physical done by his PCP. We are in our primary doctor's office. We're not in a hospital, okay? So do we think if my patient is independent in his ADLs but need help with balance and bathing, do you think that means my medication's working? It's not working? What do you think's happening? Good job, guys. It is effective. That's really awesome. He can still do his activities of daily living. Balance with bathing, that's pretty normal for someone of his age. So as long as he can do his ADLs, I'm pretty happy. What about he walks independently with a walker? What do we think about that? Yeah, same concept. I'm happy that he's independent, even if it's with a walker. No problem to me. What about he's having difficulty sleeping most nights? Yep, that's ineffective. It's meaning that something is going on. Why is he up at night? He's not getting a full night's rest. Remember, we take our meds in the daytime to promote kind of that wakefulness, sleep, etc. Something's not working if he's having a hard time sleeping. Maybe we need to switch the drug regimen. Maybe we need to do something about it. So yeah, it's going to be ineffective. What about he has a rash on both of his legs that responds pretty well to hydrocortisone cream? Yep, it's pretty unrelated. He's just got a rash. It's pretty normal. What about he is sometimes dizzy when he gets out of bed in the morning? Do you think that's ineffective, effective, ineffective, or unrelated? What do we think about that? What do we think? It means that his treatment's ineffective. We know that dizziness, falls, it's a really big risk for these patients. So if he's on a lot of medications that could possibly contribute to some of that orthostatic hypotension, we need to kind of work with his regimen and maybe see if we can kind of tailor the dose to him and whatnot. So that's kind of where that comes in. He has occasional resting tremors that don't interfere with ADLs. Do we think that's effective, ineffective, or unrelated? Great job, guys. Effective. Awesome. They don't interfere with the ADLs, and resting tremors are normal for Parkinson's. So he still can get by, so I'm happy. What about he has osteoarthritis in both of his feet? Unrelated. Again, look at his age. Pretty normal, but has nothing to do with Parkinson's or the medications he's on. He has 3 out of 10 pain in both of his feet. What do we think about that? Yep, again, it's unrelated. Very good job, guys. Again, here are the answers. So now we're going to do another indicated, contraindicated, non-essential. So a 42-year-old client has noticed chronic fatigue, muscle pain, fevers without a cause. She observes a butterfly-shaped rash over her nose and cheeks. After complete physical exam, she's diagnosed to have SLE. Drug therapy with immunosuppressants and anti-inflammatories are prescribed. The nurse is planning an education session for the client about the disorder and its management. So, do we think that these actions are helpful, harmful, or won't make a difference? And that's how you can also kind of look at some of these questions. So let's go down the line. Should they protect themselves from sun exposure with hats, long sleeves, and sunscreen? What do we think about that? Indicated, absolutely. What about keeping skin lesions covered with sterile dressings? What do we think about that? So I see how this one can be a little bit difficult. Remember when we kind of look at some of our definitions, a lesion is just an abnormality of the skin. What do we know patients with SLE have? They have a butterfly-shaped lesion on their nose. Do we want to cover that up? No, we don't. Remember, they have very, very dry, irritated skin. A sterile dressing is not really going to help. these patients. It's actually probably going to worsen irritation for them. So it's actually contraindicated. Report any infection to your rheumatology healthcare provider immediately. Do you think that's indicated? Contraindicated or not? Great. It is indicated. Awesome. What about bathe or shower no more frequently than once weekly? What do we think about that? Contraindicated, absolutely. These patients are on immunosuppressant therapy. They need to be washing themselves frequently. We don't want them to get an infection. What about avoiding NSAIDs while taking acetaminophen? And I know we haven't gotten this far in pharmacology yet, but what are you guys' thoughts about this? Acetaminophen, you might know it as Tylenol. What do we think about this? So this one is a little bit difficult, but it's contraindicated. These patients are normally on NSAIDs, which is great. They probably are taking acetaminophen for a fever, and it's okay. We have no other information that would tell us it's not okay. We don't have any information saying that her BUN, creatinine, whatever. But these patients are usually on a cocktail of drugs, which probably would include the two. Okay? And that's a bit more of a pharm question, so not to worry. What about performing at least 15 minutes of low impact activities and strength building exercises every day? Yeah, it's normally okay to take acetaminophen and Tylenol. It's pretty normal to take them both because they both do different things. Okay, one is an anti-inflammatory, and then Tylenol is more of a pyretic. It helps with fever and pain, fever and pain. One is more for fever and pain. The other is for inflammation and swelling. So yeah, low impact as indicated. What about do not abruptly stop taking your prescribed corticosteroid? Absolutely. Why don't we abruptly stop taking corticosteroids? Why? Adrenal crisis. A little bit. Cushing's. Absolutely. Cushing's is that like rebound hypertension from coming off of steroids. It also contributes to that buffalo hump, moon face, hyperglycemia, all of that. So we must taper our steroids. Okay. Be cautious with the word adrenal crisis, because a lot of I know like an Addisonian crisis, which is kind of the opposite of Cushing's, is more of your adrenal crisis. So the answer I was looking for was Cushing's, but similar concept. What about getting the influenza vaccine every year? Absolutely, it's indicated. Why is it indicated? The influenza vaccine, it's not a live vaccine. Remember, these patients cannot have live vaccines, but luckily the influenza is not live. What about eating a low-calorie diet with less animal protein and fat? Correct. It's non-essential. Maybe she is trying to lose weight, and we know that getting our protein and fats from plant sources are a healthier alternative, but it really doesn't have anything to do with SLE or the situation. Should we have our patient rest more when fever is present? Absolutely. Awesome job, guys. Great job. Again, here's answers. Now we're going to finish up with smoking cessation, okay? So we're just going to review pack years. We're going to give some healthier alternatives, address the first steps, and review our aids to quit. So all forms of tobacco associated with very serious health risks, okay? Benefits of smoking cessation include reduced incidence of coronary artery disease, prevent further damage to the lungs. This is the one I got a little bit confused with in the COPD practice question. Smoking cessation will prevent further damage, but smoking cessation will like improve like symptoms and function and stuff like that, okay? It will reduce the risk of cancer, and it will improve our overall cardiovascular and respiratory health, thus improving respiratory symptoms, okay? Pack year is pretty easy to calculate. All you do is multiply the packs per day by the number of years smoked, okay? Pretty simple. I'm not entirely sure if one pack is 20 cigarettes. It's not super important to know. Like he'll give you packs. He won't give you a number of cigarettes. But thank you, Patrick. It's 20 cigarettes. Something new I learned. Pretty cool. So yeah, just how many packs you smoke per day by the number of years smoked. If I smoke 2 packs per day for 5 years, I have a total of 10 pack years. Dr. Rosales asked us a question in class with 36 cigarettes. Okay. Thank you for that. I will, for the future, include the 20 cigarettes in a pack for previous lectures. So thank you. So are we ready to quit? The first thing we're going to do is choose a start date, and we're going to get some support. Some other ways to stay successful in recovery: avoiding triggers, like all other things we've talked about today, avoiding triggers, create a list of why reasons, drink plenty of water. Weight gain is pretty expected. These patients will probably be a little bit more snacky because they'll be hungrier. We know that smoking can kind of suppress your hunger and appetite. And when we get rid of that, they might be a little bit hungrier, which is a normal finding. However, have them substitute some healthier snacks. So maybe swap out your chips for carrot sticks, because they're probably going to want to be keeping like their hands and mouth busy. So carrot sticks, celery, some nuts, anything that's healthier for them. Participate in activities that keep your hands busy. Again, they're used to constantly putting something in their mouth and constantly taking it out. Again, we just really want them to be successful in their recovery because of all the really awesome, amazing reasons. Now we're going to talk about nicotine replacement therapy. There's multiple different types of NRT. Just know that if the patient is still smoking while they're taking NRT, this puts them at increased risk for seizures. Okay, so that's just something to keep in mind, which is why we really want to make sure that we've set them up with resources and everything that they could possibly do to help aid in their recovery. Okay. Patches are the most common. They range in size and dosage, and this really helps our patient kind of get used to that. In the hospital, you're not allowed to smoke. So even if your patient has no intention of quitting, you still can give them patches because they can't smoke in the hospital. Lozenges are common. They're like a cough drop, so they have to suck on them. You don't just take it, chew it, swallow it. No, you suck on it. It's like a cough drop, but for nicotine. Gum is also common. Just review how to educate your patient to chew until they feel a tingle and park it in their cheek. Also, we don't really want them consuming much before because it can kind of mess with the gum and its efficacy. Inhalers and nasal sprays, they are options, okay? They're just not common, but they are options. Varenicline also helps, but it is contraindicated in any sort of cardiovascular disease. So just keep that in mind. And it must be taken with a full glass of water. Bupropion, this is an antidepressant that can be used to help, but it's contraindicated in a lot of sort of cognitive situations, such as seizures, bipolar, head trauma, bulimia, alcoholism, etc. So again, just keep that in mind. So I have one more question for you guys. Let's work through it. Varenicline is prescribed for a middle-aged client for smoking cessation. What is a priority action for this client? And I know you might not have covered this in pharm yet, and that's totally okay. I'll walk you through the answer. But just in case one of the classes did cover it in pharm, this is more of a pharmacology question. Excellent job, guys. It is number 2. Tell the patient that nausea and vomiting are pretty common side effects. This drug really doesn't mess with your blood pressure. This drug is not going to have anything to do with like depression symptoms. That's more of our bupropion drug. And none of these drugs require the patient to avoid the sun. Okay. So that is everything I have for you guys. This recording will be uploaded and I will be sent it to you. So does anyone have any questions? Could you please send us this version of the PowerPoint like you did last time when you sent the recording? Absolutely. Because sometimes students have a little bit difficulties accessing the PowerPoint. Would you prefer I send a PDF copy? PDF copy? Okay, absolutely. I will send the recording and a PDF copy for you guys. You got it. And I will stay on a little bit longer in case anyone has any questions, comments, concerns, tips, tricks. Can you provide more information on the 15-question quiz you recommend we do? I still don't see it. It's actually a PDF copy, so I will send that PDF copy to you as well. I did it on Google Docs, so everything will be sent to you guys.